Hi, everybody. So I just want to, first of all, apologize to all of you. I know we've been having some issues getting our meetings off the ground. It's not anybody's fault. Unfortunately, we have quite a bad staff shortage at the Madadeni Emergency Department at the moment, which means that very often I'm involved fully clinically on the floor, and it's difficult for us to arrange the meetings. And well, today I'm on leave, so I won't be there tomorrow morning. So I said, let me try this whole thing out. So this is quite something for me because it means I can try and point and show you guys what's going on. So I'm just trying it out. Unfortunately, it does mean you have to look at my ugly mug for the entire presentation. I'll try and look into the camera instead of this weird thing where I'm doing it looking at myself. Yeah, and for those of you who have been waiting for the CPD points, they have restarted. So I've submitted all our CPDs now to the HPCSA, and hopefully we will start picking them up soon. They'll start giving it to your profile as well. So the meeting that we were meant to have tomorrow was actually on x-rays of the elbow. Now, it's not an extensive study. It's aimed more at the juniors, but there's quite a bit for the rest of us to learn as well. The reason why I say it's more aimed at the juniors is not really aimed at somebody who is very advanced in orthopedics, because there's a lot more to elbow fractures than what I'm presenting to you here. What I'm presenting to you here is just a basic of how you look at the x-rays. What are some of the tips that you can pick out in the vein of what we've been doing so far, which is in the emergency department, you need to be able to make quick decisions and decide who to pass on and what to do, and which patients require full orthopedic review, which can be attended to just in an emergency department, especially if you have POP privileges or you're expected to put the POPs and things like that. All right, so even though this is not an orthopedic lesson, it's a radiology lesson, but let's go for it and have a look and see. So let's start. So let's try and find some fractures. So this is something I often find my doctors struggling with. Well, I'm not talking about the current batch in case they're listening and they get angry, but let's just seen it in the past. So what happens is you get this patient, adult kid who comes in, and you have an elbow that's extremely swollen. It's swollen. They have all the hallmarks of a fracture. So it's extremely swollen. You have what you call it severe tenderness. There's decreased range of motion. They can't do anything. They're guarding it. If it's a kid, they've got it in a sling. They've got everything. And you send them for an X-ray and it comes back like this, and you don't see any fractures. Now, remember, whenever you're looking for fractures, you're meant to look along the cortex. You're trying to look for something that's going to fracture through the cortex. Now, remember, this is the bottom of the humerus. This is the radial head that we have here, and this is the ulnar head, which also becomes the olecranon eventually. Okay. So those are the bones that we are looking at. Now, if you follow this cortex, you'll actually see there's no obvious fracture that we can see. There's often hairline fractures, things that may be missed, there may be overexposure, underexposure, things like that. And it's very common with elbow fractures, unfortunately. So we have to have a little trick to actually show us what's going on. So what I want you guys to take note of is just these two little areas over here. All right, now we're going to talk about those a little bit more. So what we have over here and what the slightly darkened areas are in front are actually fat pads. It's also known as the sail sign because it looks like a sail on a sailboat. Well, this one not particularly, but what I mean is it comes out in that shape. So what happens is when a bone fractures, especially in this area, sometimes you just get hairline cracks. You get horizontal cracks, which is sometimes difficult to see on an X-ray. But whenever a bone fractures, now any of you, now the vegans and vegetarians won't get this, but those of you who eat meat will know that when you eat a bone and things like that, if you crack the bone for any reason, there's always a bit of fluid that comes out, be it marrow or whatever it is. And this is actually the leakage that's taking place over here. So even with a slight crack of the bone, we get leakage of inflammatory fluid, we get leakage of the marrow, and it tends to settle in this place, especially with the humerus. That's where you tend to get it. So, and in kidneys, supracondylar fractures, this is the most common one that you get as well. So here we can see that there is a, so here we can see that there is a fracture that's hiding in there somewhere. And this is the type of fracture that you can place in a POP, an above elbow POP. You can place in a U-slab too, although it's a bit low, but an above elbow POP with orthopedic review should be good enough. Now, what will happen is that this is actually, even though it's called the fat pad sign, there's no actual fat over there. So please, if you are on ward rounds, somebody don't say it's fat. It's leakage of inflammatory fluid and sometimes the marrow, all right, which is based in fat. Okay, so this is one of the most common things to look at. And I've seen doctors miss this on very, very commonly. You have this patient, you just don't see an obvious fracture. And in fact, it's more common to see the fat pad sign than to actually see an out and out fracture. So that's what I would suggest that you guys do. First, have a look, and it's in this area, and that's where you see it there. So always have a look. Now you can have only an anterior fat pad, and you can have only a posterior fat pad. I put this one because it has both. But anytime you see this little fat pad that's over there with this very particular shape, which looks like a sail, all right? If this one was a complete one, it would also look like a sail. Then that is the fat pad sign, and there's definitely a fracture that's going on over there. Okay. Let's look at another one. So here what we have is a fracture of the radial head. Now, again, if you look here, in fact, you can make out a little sail over there, and you can see that there's actually, now this is taken from a slightly different angle. That's why it looks a bit like that. They're actually trying to look from a bit more superior, but you can see a radial head fracture here. Now, radial head fractures, luckily, are not something to get too worried about. They're also not that common, luckily. We did recently have one kid who came in with a green stick fracture, and then what I noted was actually that with any green stick, which we'll cover in another lecture, I think in the next one that we have on x-rays, where we cover green sticks and things like that. We had one recently. So radial head fractures, luckily, they can be managed conservatively in a POP, but they do sometimes require an orthopedic review. Sorry, I had a phone call in between over there. So for me, it's like 10 minutes since I spoke. You guys, it's a few seconds, sorry. Okay, so yeah, I think I covered everything that has to do with this patient, except for the fact that orthopedics should review this patient at least within a week or so. The problem is that they can displace further, especially if they extend further in. And what can happen is that they sometimes need operative management in order to make sure that it's completely fixated. Otherwise, what happens is as this patient, because of the tendon connection, especially the bicep tendon connections, and some of the other muscles within the flexor, because they do attach in this area, you can sometimes get quite severe displacement if POPs are removed and there's been no monitoring of the patient. So that's one of the important things to make sure of. All right. So let's look at one here. So this is an olecranon fracture. Okay, so as you can, I mean, it doesn't take a genius to tell you that this is quite serious. Okay, and now this can happen due to direct trauma to the olecranon or even indirect trauma. So in other words, a trauma here can fracture the olecranon. All right. In this case, you can see even the radial head is displaced and things like that. So this was a push from this side, all right, that actually caused the fracture over here. Can also lead to splintering of the humerus on times, but it's not really important in this case. It just doesn't have it, all right? And then if you pull the triceps, so what that means is if the patient overextends the hand. So in other words, if you get this, now sometimes during accidents and things like the hand can actually twist past. So in other words, you can imagine this going below the bicep. So that's when you can actually get, sorry, it's not letting me point at it exactly. So that's when you can get this type of a fracture that happens, okay? So it's just with severe overextension, then you can get an avulsion fracture, which is normally not as bad as this. It normally tends to be around the edge of the olecranon around here. The main thing to worry about with these injuries is that the ulnar nerve is also running around that olecranon as well. Now, you don't need to be a doctor to know that that's a problem, because we all know that we've got our radial and ulnar nerves running over there. You can feel it when you move the olecranon, what's commonly referred to as the funny bone. So, those are the nerves that are running along that olecranon. So you need to make sure that you assess ulnar and radial nerve function as well, but the ulnar nerve injury is more common than the radial nerve injury. So make sure, just have a look. How do you assess ulnar nerve injury? You check for, sorry, I'm moving my hand in the wrong way. So you check for sensation and movement over the 2.5 fingers, I think it is. And then you have to look for the patient being able to close the fist, sensation, motor movement, and all of that, just to make sure it is there. And of course, you're talking about the outer half of the hand as well, of the forearm. If there's any sensation, heat sensation, cold sensation, vibration, all of these things that we talk about but never do, unfortunately. Okay. So this is something that's quite interesting, and I actually don't want you guys to worry about it too much. I just wanted to show it to you all. So this is ossification of the elbow. Now, this is extremely important, especially if you work in pediatrics or if you are in an emergency department, because of the possibility of fractures along these and displacements. Even though we're going to discuss it in greater detail in our next meeting, but you've got all your Salter-Harris fractures that can take place in this area. So it's important to know what you would call it, more or less where the ossification points are, when they occur, and when it's possible for them to, what you call it, have Salter-Harris fractures in that. Now, there's a mnemonic that I'll teach you as well, but I must be honest, I've given this lecture many times. Every time I give the lecture, I make sure I go back and I look at the mnemonic because I can never remember it. And I can never remember the ages as well. You need a big brain, you need a slot for an SD card or something inside there. And maybe you can remember. So, this is just to give you an idea of what it is. The thing is, if you get stuck with a patient like this, it's very easy just to quickly Google it and you'll get a picture like this that comes up, and it'll give you an idea of when the ossification happens and at what time. So this is what it looks like. So the mnemonic is crito. All right. So that means the capitellum. All right, is number one, which is here. The capitellum is the first part. And then you get the radial head, which comes in after that. And then you go to the medial or internal epicondyle. All right, here it's called medial, but there they call it internal. Okay. And then you come to the trachea, which is here. Okay. And then to the olecranon, which is there. And then finally, you come to the lateral or external. Okay. So this is a nice picture if you want to save it as well, because it gives you the years also at which the ossification ossification occurs. So 1, 3, 5, 7, 9, 11. So it gives you a nice idea of when it happens. I've got this on my phone so that we can always have a look at it and see, especially when you're looking at elbow fractures for kiddies, right? So this is just to give you an example of medial condyle fracture. All right. Now, the first thing is, even before you get this child, what will happen is the child will be in severe pain. The child will be guarding the arm. The child will be refusing any access to that arm whatsoever. These are not the type of children that come the next day necessarily. They always tend to come on the same day, late at night, after they've been injured, depending on how worried the parents are. There's always quite a bit of soft tissue swelling. So that's one of the first indicators that something is wrong, even though you may not necessarily be able to pick out the fracture. Some of these are very subtle, all right? Some of these ossification points or Salter-Harris fractures are quite subtle. So what you've got to look at is all of this swelling, all of the clinical picture, because remember, we don't treat x-rays, we treat patients, all right? So it's common, it's very common in children, and it's also commonly missed as well. And it's one of the reasons that we always compare both sides. So it's something I always tell my interns, I tell my new commsubs, because I see it's something that people don't necessarily know. Whenever you have a child below any child, what doesn't make a difference what joint you are x-raying, make sure you do both sides. The reason why I say this is because you will not be able to remember exactly when ossification takes place in every single joint in the body. You will mix it up. So rather do both sides, right? So if you have a wrist, do both wrists. If you have an elbow, do both elbows, blah, 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 blah. You make sure you do both, and you always compare one to the other. If ossification has taken place, no problem. That's fine. You know, you don't have any issues. But if it hasn't, it gives you a chance to compare. So for example, on this patient, you can see there's quite a wide gap between the medial condyle and the rest of the humerus. And if you were to look, for example, on the other one, you would notice a much closer connection over there. So this, for example, because there's nothing else going, there's no other fracture going through the epiphysis, and there's no fracture going through the physis. This is a Salter-Harris one, but we're going to cover those in another one. So if you guys want to read about it beforehand, that's great. But even if you don't, we will cover it in another one. Okay. All right. And then if we look over here, then we can see what may look like a fracture here is actually just the, the capitellum that's there. Okay. But this is the important one. And you can see the amount of tissue swelling to the point that there's actually stretch of the tissue planes over there. All right. So it is very difficult. They're not easy. And sometimes people, because you may not see an obvious crack, you think that, listen, there's nothing going on here. But that's why I say don't treat the x-rays, treat the patient. One of the biggest things to worry about is, number one, the amount of swelling. The amount of pain is subjective, but generally kiddies don't lie about their pain. And in kiddies, the biggest thing that can let you know what's going on is tenderness and range of motion. So even if the kid is not letting you touch, but they're letting mommy touch, that means, okay, that's fine. You know, there's not much going on. If they're not letting you move it, but they're letting mommy move it, then you know you've got to be a little bit less worried. But if they're not letting mommy or daddy touch their hand as well, not letting mommy and daddy move their hand, they're keeping everybody away from their joint. You should be extremely worried that something is going on here. I need to be more worried about this kid, and I need to make sure that I sort out this kid before this kid goes away. So those are the times when we ask for orthopedic reviews, we explain our patient. It's one of the things I always say in the emergency department, we are the advocates for our patient. Now, there's sometimes we get tired of fighting, but you have to fight, especially for kiddies. So these are the times when we go and we present the patient with a big smile on our face. We go to the orthopedic and say, hi, how are you? How's the family? Listen, I got this kid and it's extremely swollen and you can see, and blah, blah, and give them the whole story, give them a sweet, give them a chocolate, whatever it is, whatever make orthopedics happy. And then say, but please, can you have a look as well? I think I may be missing something. All right. Bring the x-rays, bring the child. And very often you'll find that they do pick it up because they are looking at these more regularly than us, So unfortunately, you have to play nice sometimes in order for the patient to get the best one. All right. So here's another one, and we can see how bad it's come out. All right. So this is quite a bad Salter-Harris as well. And it's a Salter-Harris 1, which means that it's just the physis, not the epiphysis or the metaphysis. It's just the physis. And this is a very common fracture in kiddies that's often missed. The problem is that now that the epiphysis is now detached from the physis, there's no longer growth that's taking place. So there's no, you must remember, you've got all your osteoblasts sitting over here. So those osteoblasts are no longer, functional. They're not functional. So you're going to get a limb shortening, you're going to limb deformities, things like that. So it is extremely important that you do go through it. Okay. Now, very common ones that we see almost every day, supracondylar fractures in kiddies. All right. Now, supracondylar range from grade 1 to grade 3. Grade 1 being very minor, almost little cracks. Grade 2 being obvious fractures, and grade 3 being obvious displaced fractures with sometimes with neurovascular or without neurovascular involvement. Okay, so what we're going to do is have a look at this one first. So what we can see here is that we can actually see that fat pad. Now the anterior one is not as obvious, but the posterior one is quite obvious. And it's the same thing. Nobody must touch my hand. Nobody must move my hand. Stay away from me. I'm in pain. And if you touch me, you're going to cause me more pain. It's a simple but effective way that children communicate about how bad things are. All right. So this kid won't let you go near this arm. Now, in this case, they're just trying to show you can actually see the little crack over there if you look really closely, but this is a nice one. You may not necessarily see it. All right. So once you've got this, now these patients do need to be seen by, well, if worse comes to worse, you put them in above elbow POP. You just confirm neurovascularly that they are intact because it's for medical legal reasons. Patient needs to be reviewed the next day just to make sure the POP is not swollen. The normal things that we do for a patient who is having any sort of fracture like that. And then for review by orthopedics again after that, depending on your situation, where you work, how the protocols of your institution. But like our protocols, we normally hand these over immediately. We don't place the POPs. And orthopedics takes over their patients and they manage them right through, which is quite good. Here we have an example of a grade 2 supracondylar fracture. So here you can actually, now this is an elder patient, all right? But in kiddies, you can also get a similar thing. The only thing is that there is, I'm being now a bit silly. This is just slightly elder child. No, this is I don't know. Anyway, let's not worry about it. I'm actually just worried about this. So you can see this little step that we've got over here. So this is quite an obvious fracture that's occurred over there. So that's a type 2 or a grade 2 supracondylar fracture. Now, this is also something that we need to take note of. Now, this is a large joint effusion, and actually you can see the dissociation of the olecranon from the rest of the joint as well. Now, the reason for this effusion, we actually look very carefully. It took me a bit of time as well. You can actually see that little hairline that's running through over there. And if you follow it, I think you can actually follow it right down till there, but it's a very tiny hairline and it's a large effusion that's happened. Now, there's most likely hematorosis that's happening over here. So for those of you who don't know, now hemarthrosis, one of the major signs of it is locking. So I'm just going to use my finger as an example of the elbow. Sorry, let me just get it up a little bit. So whether it be the elbow, the knee, the finger, whatever it is, what happens is that it can only move up to a certain point and then it locks. The reason for that is that the blood forms a physical barrier. The clot actually forms a physical barrier to the joint moving any more than that. So if you had a knee, for example, and the patient had a hemarthrosis, they'd only be able to flex till there. No matter what you do, it would never go past there with quite a severe swelling. Now, effusions are normally quite easy to make out. Joint effusions are a bit difficult because it's a relatively small joint, and normal fractures can also lead to that. So what you see on a joint effusion, it's the equivalent of a fat pad. You can see the difference. We've seen fat pads now, and you can see this massive amount of leakage that's happened over there to the point that you actually have dissociation of the radial head and the olecranon from the humerus as well. Now, this is quite a serious thing. This is not the type of thing that you would stick a needle in and actually remove it. The reason being the amount of potential neurovascular damage that you may have. So this one in particular, it's quite, if I remember my orthopedics correctly, because I did this a long time, about 20 years ago. If I remember correctly, it's a posterior approach. There's a bursa that's here. You've got to get into it, open the whole thing out, do an internal reduction, but things may have changed. You know, the last time I did it, it was quite different as well. Again, I'm so sorry. I received another call as I was recording this. So I think we've kind of finished with the joint effusion. Let's move to the next one. So these are quite severe supracondylar fractures. All right. Now, in this case, these need, when we say urgent reduction, number one, you've got to check in the emergency department, does the patient have peripheral pulses? Now, in this case, it may, or peripheral sensation. If the patient doesn't, then normally under conscious sedation, we try and bring the joint approximation as well as we can. Now, of course, it depends if it's a comminuted fracture, severely comminuted fracture, things like that. It may be difficult, but we have to try and get the joint as reduced as possible so that we have a, at least we have some sort of relief on the tension on the neurovascular bundle so that we can proceed with the patient. Now, of course, even if our reduction is not working, then of course we need to call the orthopedic surgeons as quickly as possible. The patient needs to be taken to theater as quickly as possible for an emergency reduction, emergency RF. Although it doesn't happen very often, we should be able to reduce these. It shouldn't be much of a problem. Okay. And remember, it can be very difficult without sedation. So we normally do it under ketamine. You may have to do it under whatever you've got available, morphine, dormicum, Valium. It doesn't make a difference, just so long as you get it reduced and get that blood flowing and get that nerve working again if you can. Now, the nerve is not as important because it takes a lot longer for a full paralysis to occur. I mean, of course, the vascular is a much more urgent thing. So we had quite an interesting one a little while ago. That was actually an emergency reduction done quite quickly. We had a young girl who came in with a fracture that was actually similar to this. And the brachial artery was actually stretched, if I can put it, from there across here. And you could physically see it because it had moved anteriorly with the movement of the hand. So you had the entire neurovascular bundle lying along the anterior and then moving along. And it had a similar picture to this, which, sharp shards of bone coming out. And we didn't want to attempt the reduction because there was a possibility we may have clamped it between the sharp shards, So it was a very odd case. The first time I've ever seen something as bad as that, with such a bad open fracture, such an easily visualized vascular injury and things like that. But orthopedics did rush her in. They did do an urgent reduction. Luckily, there was no vascular damage. It was just vascular stretch. So once they reduced carefully and moved the vein and nerve, artery and nerve out of the way, the young girl's hand was okay. But you do get these odd ones sometimes. And when you do get the odd ones, always ask for help. Make sure that somebody knows, either senior or from the specialist department. Okay, so these are obvious fractures. I mean, we don't really have to go through it. And you can see how posteriorly dislodged the entire head of the humerus is here. So you can just imagine how the neurovascular component will be stretched as well. Okay. So here we have an elbow dislocation, posterior elbow dislocation, which is the most common that you get. There's always a possibility of neurovascular impingement and of neurovascular, and of especially of vascular stretch and neurological stretch. So we want to try and get these reduced as quickly as possible, because again, you've got your artery that's running around there. It can pop to the front, or it can get impinged depending on where the dislocation goes. So what happens is at the back, you have this very prominent or ulnar head. You can't miss it. Let's put it that way. Normally your elbow is quite a nice, what you call it, smooth transition across there. So what will happen is the entire ulnar head just moves backwards. So you can run there, and then you got a step that comes like that. So it does that and then goes in. So, it's quite easy to make out. Normally with these, I try to reduce them in the emergency department unless they're vascularly intact. So if you've got very good pulses and things like that, then we don't really touch them. And the other time I'm a bit scared to actually reduce them is when you do have associated fractures. Like here, we've just got a small fracture that's showing over there. Now, of course, if the patient is vascularly compromised, you would still try and reduce to try and get the vascular component going, but you need to do a control X-ray to see what would have happened to any fractures thereafter. Okay. So this is quite important. Patients will not move. They will keep their arm as straight as possible, and they will not let you touch it. So you have to do it under sedation, conscious sedation. Again, the most common one we use is ketamine in emergency departments. There's a joke going around that if you find an emergency physician, they've got their Monster Energy drink and the ketamine vial next to them. All right. So you need to have ketamine if you're working in an emergency department. Those of you who are working in emergency departments and don't have, please make sure you get them. Okay. So how do you reduce it? Oh, I'm in front of this thing now. Sorry. So I'm going to move off to the one side. Try. So it's like any type of reduction. You need traction, and you need counter traction, and then you need to put firm pressure on the olecranon itself. So as you are pulling it, it actually is quite easy to reduce. It doesn't take a lot of force. You're just basically pulling the humerus back, pulling the ulnar and radius forward, and just keeping pressure on that ulnar head. It actually pops in very quickly. It's a very easy reduction to do, unless you are doing it with a conscious patient who's screaming and trying to hit you at the same time. So always make sure that there is sedation when you do this. Okay. I think we're coming up to the last slide. Yeah, so that's just a little joke, sorry. So just something just for everybody just to have a bit of a laugh. So I hope you guys enjoyed it. Let me try and make myself smaller. Maybe then you can enjoy it a bit more. Sorry. And let me put myself over there. Aha, there we go. All right. So I hope you guys enjoyed it. And hopefully next week we'll have a live session. Like I said, because I'm on leave, I'm not going to be available in the morning tomorrow. So that's why I recorded this and put it on. And in fact, from the time that we started this to now, I see actually those of you who are waiting for CPD points, you'll actually see your CPD points coming in. So please make sure you keep those emails. Don't delete them, because that serves as proof that you've watched this and that you've attended this as well. All right. So the CPD point for this, I will only submit the register tomorrow. Yeah. There we go. Hopefully everybody enjoyed it. And yeah, next week I'll see you guys again. All right, keep well. And if you didn't enjoy looking at my face throughout the whole thing, please let me know, because the next time I record one, then I know I don't put it on. And yeah, if I made some of the guys and girls heart flutter, let me know as well. Then I know I can do this again. All right, no problem. All right, everybody, keep well, and I'll speak to you all soon. Bye.